So first, thank you very much for inviting me here. It's always lovely. It's quite a few of the same faces, but I see quite a few faces I don't recognise. And also I see a much increased audience. Every symposium we seem to have is getting bigger. And it's very nice to see. Okay, the case I'll show you is of Sophie. There's her extraoral photos and her general information. She came in when she was a little bit old. One of the reasons I'm going to show you Sophie is because it's slightly easier to diagnose older faces than it is younger faces. When you're faced with a 6-year-old, it's very hard to spot if there's anything wrong at all. When you're faced with an adult, you can nearly always see what's gone wrong. And most people can tell at about 10 to 11 when something's gone wrong. When I give a lecture and I talk to dentists, they frequently then refer me 10 or 11-year-olds because that's when they can see or they identify with what I say. So by showing you Sophie, who's in that range, it's a little bit easier to see what's happened on her face. So not really any relevant medical or dental history. She had 2 elder brothers and an elder sister who had both had conventional orthodontics, which of course had made their parents look for something different. So they came looking for something different. So we're very interested in orthotropics from the outset, and we're very impressed with what we said. I explained yesterday that the 3 most important things I look at when I'm taking on a case is the muscle tone, the age of the person, and the parental support. So I'll always ask a few questions about their parental support. So she's got good family support, living with both parents. Mother's not working. Mum's a professional mother, housewife. That's her job. She's behind the kids. That's just what I wanted to see. Both mum and daughter were committed to treatment. And of course, Sophie is very conscious of her appearance. So I'll go through the approach I'm looking at when I'm assessing the case. So first of all, I'm looking at the body posture. Presume that's... Okay. I look at the body posture. Most people have got a forward head posture. I mean, nearly everyone has a forward head posture. Then I'm looking at the general head shape. She's slightly brachyfacial. Then I'm looking at these facial planes, the line between the ears, the occlusal lines, and the mandibular planes. So what I'm looking there is the line between the eyes, the interpupillary line. I'm looking at the line going between the ears. And then, well, I would be looking at the occlusal plane, but I didn't take a photo of her smiling, so I can't show you that. Then, of course, I'm going to look at the upper and lower indicator lines. Now, then I'm going to try and get an impression of her upper and lower jaws and the space in between. And teaching has taught me a lot about understanding how people think. Oh, there's a pointer. Thank you very much. Which one? The top one?
Doesn't matter. Either one.
Okay, either of them. There you go. Oh. Anyway, does that work? Yeah, I can see it. So this is a colourblind thing. It's not easy. Yeah? So what I want to assess the upper jaw, and I want to assess the lower jaw, and I assess a little bit in between. And to test myself, I'll go through the tube in London, trying to assess every single face I see. Because this is a good test for yourself. You've got to analyse all the faces, not just the 1 or 2 ones that come into your clinic, to try and assess what's going on. And so I came up with this kind of idea, this kind of concept, that here I was going to look at the, this line across here, looking at the upper jaw, and this line here looking at the lower jaw. Then I look at this space in the middle here, this space in the middle here, and I'm looking at my indicator lines. And then a general assessment of the anterior vertical development of the face. And then I wanted to have a good understanding about the face and which bits of the face make a difference. So, obviously the soft tissues are affecting the hard tissues. Within a group here, we take that for granted. But we've got to understand what bits are affecting what. So I've broken up this face here, suggesting that that's really at the muscle effect. By the word effect, I'm not sure if it's the resting muscle tone or the absolute strength of the muscles. We will find out one day, but right now we don't know. So I'm just saying it's that muscle effect. The section underneath the eye, this section here, I'm saying that's a mixture of the muscle and the tongue. This section here, I think that's more the tongue, both rest and function. This section here seems to be due to the upper incisors. This section here, obviously it's the buccinator and the reciprocation of the buccinator on the tongue. This bit here, it's that lower belly of the bicularis oris. Notice that lower belly there. It's going almost horizontally, and that's that chunk there. Then the mentalis. And of course, I could have drawn another section or all the way along the mandible, or extended that red section, saying that's where the muscle is having a significant effect. Now, I could turn that round and say, well, really, well, that's muscle, the muscle effect. That's the muscle effect. And apart from the mentalis, most of these are related to the tongue, with the possible exception of those upper incisors. With the possible exception. Now, that's mainly then the effect of the tongue in the central section and the muscle on the muscle effect on the periphery. So, if we compare to another person, so we've got here Jude Law, and I'll say that section of Jude Law's face is representing the tongue effect, so the effect of the tongue. So we see across from here. Okay, this is a digitally enhanced photograph, and it's also frontal. It's a little bit more difficult to assess from. But you can see there's, although it's a very nice face, maybe it's not perfect in those sections. Maybe that chin tip is a little bit further forward. And when we take an image that's not digitally enhanced, it comes a little bit clearer. And so you're seeing what I'm meaning on that. And then really, it would be nice if we could take away, or we could understand, what her face would look like if we took away that whole tongue effect. Well, we know that the tongue effect's really related to the dentoalveolar section of the bone. So if we took away the whole dentoalveolar section of the bone, we'd be left with something that looks a little bit more like that. It happens. Although I'm probably not sure about how much of that section there has been affected also by the loss of the teeth. Of course, well, when we bring back that to thinking about how that was with Jude, I think you can almost see this bucket handle here, hidden here underneath the mandible, as if it's almost rotating up and forward, affecting how that bit of the face is. Relating it back to that image I showed you earlier on. And then, of course, watching Jude through a period of time really makes it obvious. This is where I'm trying to teach you to pick things up with your eyes. Because from this point to this point, I think the balance has changed. his facial shape is more determined by the muscles than by his tongue. So that's just to try and bring something in there. Now, I think it's a little bit unfair to compare Sophie to Jude. But now we come back to Sophie, so we can see down this section of the face here. You see that nice chin tip she's got there? She's got this great big chin tip, but as we're going to find out, she's got a reasonably decent overjet. And on a canine, she's a bit class 2. But, you know, that's a good chin tip. And I think often when we're doing cephalometric analysis, because that point B is set back due to the position of the lower incisors, that's distorting what we're understanding from our cephalometric analysis. So to go back onto track where we were going to look at that upper jaw, the maxilla. And I'll say with that maxilla that she's got this sort of moderate lack of eye support here. Got this flat area under the eyelid with this sort of, you know, you have that sort of 45-degree angle it cuts out at here. You know, she's not an obvious case, but some people, some children, you have that obvious 45-degree line that runs out. From the inacanthus of the eye running inferiorly and laterally. Of course, we've got reasonably wide nasal openings, the alus, as Jose was describing. And of course, we can talk about that cheek line. And that cheek line's here. It's going down from the infraorbital area, down the sort of anterior cheekbone, and comparing that to the nasal line. Just makes that section here look a little bit bigger, makes the nose look a little bit larger. So you just need to be a little bit in tune to that. Then, of course, as far as the mandible, its mandible steps down slightly, but, you know, her head posture is a little bit forward, so that might account for it. But the overall length from chin point in relation to the face is generally quite good. She's got this deep labiomental fold with some activity in the mentalis tramain ellipsoid. You can actually see that mentalis activity she's got there. But when I'm trying to assess if people have got good muscle strengths, what I'm looking at is a nice big length of mandible. You know, that Angelina Jolie section of mandible. Then, of course, I'm going to look a little bit closer at those lower lips. Now, that lower lip's slightly averted, slightly large, it's averted, and it's a little bit prominent on the aesthetic line here, isn't it? Bit of a hooter of a lip. But it's that curl, and I think that lip's not really large, it's just flipped over. If I was to take her lip and roll it backwards, I think it would look very normal. I don't think it would actually look very large. But what we're really looking at here is this cleft here, and this bit of the bicularis oris there. I used to have an Iranian girlfriend, and she used to take a lip marker, and she would make that lip marker run along the edges to try and accentuate the vermilion border. Now, get good lip function, you'll get a good vermilion border automatically. Here, that muscle's destroying the vermilion border by running through. Remember I showed you that lower belly of the bicularis oris before? Remember that section we showed you? So there, that's that bit of the bicularis oris. Now, sometimes it's a bit difficult to pick up, so let's go and look at someone a little bit older. So here we've got Mick Jones. Of course, you'd all know he was the lead guitarist of The Clash. And of course, I think over his time he's learnt to keep his lips together by using that orbicularis oris, because he realised how stupid he looked hanging his mouth open. And of course, when you're in the public eye, you want to keep your lips closed, because that looks better than, it just looks more educated. But here you can see that bicularis oris there. So now go back to Sophie. Now it's suddenly more obvious, because you've seen an obvious case. Such is the process of learning. So remember this diagram, this as you go to assess people. And do that same thing, just everyone you see, assess. Because it's the numbers game, and that does make a difference. Now, then this is what most orthodontists would jump to, but I've left to last. Is this, almost last, is this intraoral section. So we're class 1 on our molars, a little bit class 2 on the canines, and we've got this bit of an overjet. It's actually a reasonable overjet. It's an 8.2 millimeter overjet. But that's really that lip catch, isn't it? There's that lip holding back those lower incisors that I haven't actually got a shot. They're just mildly imbricated there. And she had a reasonably wide upper arm arch of 36 millimeters. So, and function, posture, lips were open 7 millimeters much of the time. And what we're trying to do now is looking at this intersyllable rest position. So, assessing lip apart posture in a dental chair, I sometimes think is a little bit like assessing the freeway space. That's the freeway space or lip posture that they're presenting when they're in your dental chair for their first examination. And I don't think that really relates to how people are normally. It's a stressful situation. They're not really going to show you how their lip line is. I find a much better way is to watch them in the waiting room when they're reading a magazine. That's going to give you their impression of their lip position. So a diagnosis, moderate, I'm using this term craniofacial dystrophy, describing the underlying pathological process of what's going on. With a large overjet but mild malocclusion. She's not a serious case. I want to show you a case, the type of one in a younger situation that would be good to tackle if you didn't have a lot of experience. Lips apart 7 millimeters, with good rust muscle tone, and a slight tongue between tooth function. A little old, good motivated, and good family support. Not a perfect case, but it's worth a try in this situation. So standard orthotropics, no additional features, except possible elastics for anti-alignment, estimating 6 months preparation time, expanding to 42 millimeters or more, 18 months full-time training, and then retention until she's somewhere in the 16, 18 years with some orofacial myology, although I've written oral myology there. Limitations of treatment. Well, over the age of 9, it's unlikely that we're going to get much change in that maxillary area under the eyes. So I don't think we're going to get much change here after 9 years old. It seems to tail off a lot after that age group. Unless really we go for 2 cycles of treatment. I've seen if you do 2 cycles of expansion, then stage 3, expansion, then stage 3. Or so I say, training, preparation, and then training, preparation, then training. There's also no possible to extract the deciduous dentition. It's been lost already. And then our risks, well, really it's the failure to motivate her posture and function. Because all I'm doing is I'm giving her a chance to improve it. I don't make it better. And I have to remind that to her constantly. All this is for you is an opportunity. We can get lower labial recession. Well, when we're tipping the lower incisors down to create our initial preparation with an anti-open bite, you can get damage to those lower incisors. And there's problems associated with stopping treatment with midway with a residual upper expansion, lip catch, and scissor bite. They can all happen. Damage to upper incisors during the prominent position during the first stage of treatment. But generally, orthotropics is very fail-safe, and any level of improvement is of benefit. So the treatment progress. We placed a stage 1 in June. We re-zeroed it, which is the process when those screws go more than 30 turns, I'll flow some acrylic into the actual screw mechanism to prevent them going back any further. as I have had problems with screws becoming a little bit loose. And I want to turn back each one so I know exactly where I am with my turning. So when they come in, I get my nurse to turn all the way back till it stops. Count each individual turn, which we check against the calendar, against each individual day that has elapsed since we last saw her. So I can turn around to her and say, you're one turn short. What happened? I'll say, oh, maybe that's the night you went to stay with your granny. Ah, well, next time you see the granny, make sure. When kids know that you are on their case, or in fact, when anyone knows you're on the case, a different behavior occurs. So then the training phase started. Or I'm going to go back. So that was, it was shorter than expected, but of course, she was already relatively wide on her, in her maxilla anyway. We gained 6.1 millimetre of expansion in 47 days, which was going at a rate of 0.9 millimetres. It's worth reflecting on that, because we say we're going at 1 millimetre a week, but do cases always go at 1 millimetre a week? Probably not always. Probably not often. And I think in reflection, I might have actually widened her a little bit wider. We fit stage 3 in September. She started wearing it at night quite quickly because she was older. If they're older, they understand what they're doing, and they're quicker to go into nighttime wear. We had an issue with an ulcer. We started using tape in February. We started using some elastics on some hooks across the anterior teeth, so that we were pulling the anterior teeth back upon our cat wires, which just helps to straighten them for aesthetics. And then when we started reducing the wear, that's when we hit in with our orofacial myology. Because when you have an appliance in the mouth during the daytime, I think it's not going to help you out with your tongue training and lip training. And that step, that sudden step when we stop wearing the brace, is a great point to intervene with that therapy, because that's a good moment to make it work. So in total, that was 19 months. We had a small residual and overjet and overbite, probably associated with that mentalis action and that tongue between tooth habit. So it was an excellent moment to move to the orofacial myology. Now, over that period of time, we had one visit where her L number was 0. We had 4 visits where L number was 1, 11 visits where the L number was 2, and 2 visits where the L number was 3, and 2 with a greater level of that. And by what I mean by L number, it's that from their intercuspal, or their biting position, when they drop down, that's the distance until the anterior locks touch, engage, till that proprioceptive response cuts in. And then we've gone into our active retention phase. So once we reduced that wear and started the orofacial myology, till the present, it's been 33 months so far. We fitted a new stage 3 at the end of last year. A year before, actually. Doesn't time fly? So far, it's been 33 months. She's now 17 years, 2 months old. We reviewed the 17th birthday, and she wants to continue. She's just wearing this at night. I've said to her, this is this long tail. This is one of the new developments we're really trying to push in our clinic. It's getting them wearing this long tail because it seems to be very, very beneficial. And of note, the last 2 L numbers have been L1 or less. It's steadily getting better. Each time she comes back, I'm adding less. Once I didn't add to her. So this was how she looked once we'd done our preparation phase, with the facial features there. That's where she looked when we went down to nighttime wear, and that's how she looks when we finished. That's her dentition when we finish, and you can see we've still got that spacing in the upper. So when we look at this, we've got the nice, our canines more or less into class 1. They're going to drop into class 1. We've just brought everything forward by a reflection of the fact the molars have gone back. And that's probably not actually the amount the molars have gone back, because of course Newton wasn't wrong. Those molars must have gone back a little bit as I pushed the incisors forwards. But it's a reflection of how much everything's come forwards. And that's our comparison with a dentition before and after. And that's a comparison of our face. I'll go into a little bit more detail. So that's the step-by-step comparison of our dentition. Our blow-by-blow account. As you know, I'm not desperately interested in straightening teeth up, because you will either straighten them yourself and keep them straight, or you can artificially straighten them and they won't go straight. And that, of course, is our facial change over that period of time. And so really quite a nice facial change from the beginning to the end. I look at that from the 3/4 view. I actually think we did make an effect. Of course, her head is in a slightly different position. And with 3/4 views, it's very difficult to compensate for that. And if you ask someone to tilt their head back, the angle the eye's looking can easily make that sort of change. That can easily be just the way she looks with her eyes. A much better comparison is to get her looking at the same point, trying to match this point here, to give you a much clearer example of what's going on with the mandibular position. But you can see why she is quite happy to wear that brace at night. Sophie cares about how she looks. And as I've used that to the maximum to push her treatment forwards. Now, so what new developments am I trying to do to get this change in everyone? Well, to some degrees, I'm being a little bit patient-driven. I have quite a lot of adults that are coming to my clinic. I blame it largely on Bill Hang, because, of course, they're seeing his website. Then they're working out that, well, Orthotropics and the name Mew seem to go together. And then they're hunting me down in the UK. And a lot of adults are coming in having done a lot of research. The type of person that opens their folder and starts bringing out information at the consultation. And you can see the word Google everywhere. And you've got to learn as much from this as you can. And largely, these patients have pushed me forwards. They've taught me a great deal. And you know, you have to these days stay open-minded, because you will come across lots of people who will know an area better than you do. It's not difficult with the internet. And this lady came in. I showed this image in Chicago last year. And she'd been under treatment by someone called Dean Howell, who's got this concept of neurocranial restructuring. It's not like orthotropics, but she was wearing what this is an effective forward pull headgear. They only wear this for 15 minutes a day. You couldn't cope with that pull on the lips any more than 15 minutes. And even then, she's got 2 red marks, and it's uncomfortable. So I looked up Dean Howell. He's got this site. To be honest, it sounded very, very left field when I checked it out. But I contacted him. He had someone working, he trained someone in the UK. I contacted the guy. We arranged some patients. So this is Ian Headley. So Ian's come down, and we've got him bought a bench. Excuse me a second. That's better. So I was actually very impressed when I talked to Ian, because most of the theory they have and the ideas they have are very, very similar to orthotropics, but coming from a completely different angle. And the gaps in his knowledge, I was saying, oh, that's because this. That's because this. And he was going, oh, yeah, that makes sense. And, you know, you need to challenge everything every step of the way. And I've taken him on with the knowledge that I will challenge everything he says. I will try and disprove everything you tell me. But his concept is doing some body work and then some paranasal inflation. And in the interests of science, I got him to do this on me. And it is a little uncomfortable, to be honest. It's not the nicest thing to have done. But if we want to move this midface, upsetting this midface is a good idea. Getting some change in it. Their main concept is that normal osteopathy doesn't have a good long-term success rate, similarly to orthodontics, because they feel the head isn't sitting nicely on top of the head, or the body. And because the head's not sitting nicely on top of the body, it's bound to relapse, because of the weight of this head is continuing as the causative problem, making that problem in the first place. So their aim is to make things more symmetric and get the head back up on the head, on the body, which is a lot of similarity with an orthotropics. And of course, this works by putting a balloon, not quite like this actually, it was the best image I could find, but placing it in one of the three paranasal spaces on one side or the other side. It was interesting. I'm going to see if that can help me get that maxilla up and forwards. So I put some forward pull headgear, I do some expansion, and I do some paranasal inflation and the body work. And I thought rather than trying to reinvent the wheel, I would just get an NCR in and see how much that helped.
And like the chiropractors have been doing that for years, just using the little finger.
Yeah, I've read about that, and I've done a lot of sort of side research to try and understand what's going on and how we can help people. And but when I came with someone who already had a package, I thought, well, I can bring that package in, I can see how well I can get it working, and then we can set about improving it. And I might as well take it from that point, because so much of what he said was making sense. I thought, well, yeah, let's run with the ball and see if I can improve it. So what I also mentioned in Chicago was I'd been to see Matani in Tokyo, and I'd seen him using this ramper device. And I was exceptionally impressed by two cases of adults he showed me, where he'd really got some facial change in adults. And I think that if you can get some facial change in adults, it's a real sign that you're getting something happening. I always remember one photo he showed me of a dentist working on a patient. And he showed me this photo. He said, "So what do you think?" And I looked at the photo, and I obviously looked at the patient in the chair. Nothing untoward interesting the patient in the chair. Nothing particular about the surgery or the equipment in the surgery. And he was still sort of looking at the photo. So I looked again, and it suddenly hit me. The dentist was wearing one of these. And he goes, if you're a dentist, you're going to be very motivated to do that. But I would worry that this is quite a contraption. And he was asking for 18-hour-a-day wear. Now that's tough work to wear that as an adult. You know, you're going to get more than a few glances if you walk down the high street wearing that. You know. Yeah. So I thought, you know, ever inventive, I thought, okay, let's try and see what I can get out of what Matani was doing and seeing if I can improve what's going on. So I've gone down the hospital and I've got some of this bandage that you would normally use for casting, a delta cast. And I've then placed a face bow, and I've got some prongs at the front. So there's elastics on the prongs to the brace, and there's an elastic here. So I'm using about 2 times 200 grams here, so about 400 grams here. I'm doing about 300 grams here, so that's about 600 grams going upwards. So that's my 2 forces. I've got my about 600 grams going up that way. I've got about 400 grams there. So in total, I've got about 1 kilogram. And if you work out with the vectors in a force diagram, I'm now getting a force upwards and forwards, very similar to that headgear I showed from Dean. But of course, now I'm not totally disrupting the lip posture. Okay, you're not going to have good lip posture with all of this going on inside your mouth. But I want to see if I can significantly move the structure, then I can change the function and influence the posture. So I want to get a rapid enough change that I will change the individual. And they can go to a point where they're significantly different, that they'll maintain that change. And of course, I don't want to just keep these for old people. So we've got this is Isla. And Isla is the sweetest. She really is. And she was class 3. We did some expansion in the upper arch, hoping that it would spontaneously correct, and it didn't. So then I'm faced with, I said to Mum, well, look, you know, we had a go. Mum had jaw surgery herself. Not that I think it's a genetic condition. But Mum was very keen to avoid this. So I said, okay, well, I'm doing this for adults. Do you want me to have a go with Isla? So we had a go. And as you see, Isla's sort of organising stickers on this. We've seen to see if we can have some vague colour matching. And I'll report to you to see what changes we get with Isla, because at that age, we should get a much greater change. And what we're attempting to do here with Isla is rather than just carry on expanding, we're now going to expand and contract, and expand and contract. So we'll go through phases. Again, I'm just pulling on the deciduous teeth, so if I do cause a little bit of root resorption on the deciduous teeth, it's not going to be the end of the world. But what I want to do is see if I can just upset that midface. And I can't just expand, because otherwise I will run a limit at some point. So I will have to go both ways. Of course, then I mentioned also last, yeah, Barry.
Can you talk about the intraoral portion of these implants? What do they hook to? And
Yeah. So this is just hooked onto a stage 1 style orthotropic appliance. So the type of appliance we're using in, I've showed you in the UK. It's a upper expansion appliance without acrylic on the anterior palate, with a heavy duty, the Magnum screw by Dentarum in it, set high up in the palate, and modified Crozat clasps on the retentive tooth, just one on either side, on the second deciduous molar, the E, as we refer to. Yeah?
the advantage of this as opposed to a regular face mask?
I've been using quite a lot of Hickam face masks in young children, and I tend to find they nearly always become loose. I've had real problems in the younger age groups with headgear. The delaires, I don't think they really get as worn as well because they're so unstable. Hickham can be worn well, but in the younger people, I find it's unstable. It tends to make the brace loose, and it nearly always makes a slight downward force. And also, what interested me, sitting there talking, I've got an excellent cranial osteopath down the road who teaches in central London. We've treated all 4 of his children to better success as we improved ourselves. And I've sat with some stride skulls looking at things with him. And one thing I noticed was of great interest is that back attachments of the maxilla are sliding attachments. So when you look at the maxillary attachments, you have the nasal attachments that are paper thin. In most old skulls, they're broken because people have abused them and broken them. You've got the zygomatic process, which is where the strength is. That's a really heavy process, right just underneath the musculature, where you'd want to have the strength. Then posteriorly, you're attaching to your vomer centrally, and you're attaching to your pterygoids, palatine, sorry, laterally. Both the vomer and the pterygoid junctions, they're smooth junctions. Well, that has been described or explained because of the cushioning effect. As you bite into hard things on your molar teeth, the whole back section of the maxilla can flex up and down. It's got a little flexibility to it. And that's why you have these sliding junctions. Now, if it's got that little bit of flexibility, well, surely if I pull up as posteriorly as I can, I'm going to lift my maxilla like that. And if I can move my maxilla like that, well, then it's a shoo-in for the mandible, isn't it? Because the preparatory phase of orthotropics, you're opening an anterior open bite. And that anterior open bite's going to stay because those molars are hitting. If you could only get those molars up and out the way, then the mandible will just rotate up and close, just like taking the doorstop out of a door. So this is my attempt to take the doorstop out the door, lifting up at the back. Because if I can reduce the posterior facial height, if that maxilla is relatively flexible, because of those sliding joints posteriorly, then I can just rotate that mandible up. Of course, up and forwards, not maybe what you want in a class 3, but if I get that maxilla far enough forward, it doesn't matter. Then I've just grown the whole face even further forward. That's the sort of thinking behind what I'm trying to do. I'll have to report back to you how it goes.
How many hours?
Well, I've asked her for all night plus an hour before she goes to bed. She's what, 7 years old? So I think she's 6, actually. So I would imagine that that should be enough time. Of course, what I also described to you previously was the pheromone timer system that we're using. So I've embedded a pheromone timer. It's just actually, can you see a little bulge here? There's a pheromone timer embedded in it. So I trust no one. So I'm going to time, and they don't work as effectively, but you have to change the sensitivities on them, but they're not bad. Now, I mentioned the MRC group. I'm interested in what they're doing. I know that they're not getting a proprioceptive feedback. It's just a little appliance put in the mouth. But I'm going to go down. I've not really progressed much, but straight after this event, I'm going to go down to Australia to see what they're doing. Because science is about being inclusive. It's about not saying I do and don't disagree based on some concept or idea, but on results. That's science. So I want to go and see results. I want to be scientific about it and try and see what we can gain by cross relationships. Now, we had a lecturer earlier on from New Zealand who was very entertaining. This is another gentleman, well, this isn't, Mackenzie was. A lot of medicine is put forward and advanced by strong individuals, charismatic people. Mackenzie was a charismatic physiotherapist who noticed that lots of these people with back problems down here tended to have forward head postures. So he said, while you're working on your back problem here, you want to chin back like that. Have you heard of the Mackenzie roll? Well, it's popular in the UK. It was a roll for you can wear it, you can use in the car that goes on your lower back. But he had a method of tucking the chin back that I'm trying to rewrite and give as an exercise to the kids to get their head back and upright on top of their body. And one of the interesting things, doesn't it make him look chinless as soon as he does that? And isn't that affecting his airway? Well, of course, it is. That's why he does the opposite most of the time. So our developments, and I'm also using a lot of these chewies. If any one of you uses Invisalign or other brands of aligner systems, you can get those hard bits of tubing that you can bite the chews in place. Well, I've got the kids to chew them at least an hour a day, and I've been surprised how effective that can be during my expansion phase. So as I'm whitening, they're chewing for at least an hour a day. They're bringing me the chewies back as evidence that they've done the chewing, because I want to see them destroyed. It's no good otherwise. And I'm seeing my molars, instead of widening like this, I'm seeing my molars widening like that. Because molars will upright against a force. And they're uprighting against these chewies. The tape, I'm trying to get in there with the tape earlier. I really want to get in there with that tape as soon as I do that first re-zeroing. As soon as I'm thinking, oh, we've got a little bit of spare space in that nasal capacity now. So let's get in there with the tape. Let's start pushing it now. Then I want to move on. I'm going to want to do more breathing. I mean, I've had Patrick come to our clinic many times, but we haven't really been at a point where we were ready to implement it. I think now we're going on an expansion phase, and with our scales of economy, we're going to want to bring in some more breathing. As I'm mentioning, we want to do some more body posture. I've been very interested in some of the concept of Jose Duran's stimulotherapy, particularly the sort of nasal obturators. And then I want to get more in with some more orofacial myology, because it's something we really lack in the UK, something we need more of. So there's just an interesting of body posture, because unless we start thinking a little bit out of the head, I think we're going to limit what we can achieve. If we're only focused here, we can't really get someone to change from here to here. So we need to be thinking outside the mouth a little bit more. So, what else do I want to say today? Well, I did want to bring to your attention that we have upgraded the orthotropics.com. Now that I'm my dad's boss, certain changes have occurred. I do have to remind him once in a while he's on the payroll. So we've tried to make a really sophisticated website. It's broken into these 4 segments. It's broken into that Discovering Orthotropics with lots of information that I'd like people to go and check out and report back. I mean, Edmund, thank you for your mail this morning, I think it was. To totally take everything on board. We did have to throw some things in there a little bit. And it is the blind leading the blind a little bit with technical support's Iranian, and my English is just appalling. So, and further down, we've gone and taken lots and lots of your videos, and we're not actually hosting them. We've not nicked them from you. We've just got this is just a window that looks into other people's websites. But we're trying to give this impression of this large international organization. And this is a very good way about it. And some of the other bits and pieces that we've found popular on the other website, we've kept. And obviously, we've got a slider down here. We've got the education and events, and I think that would be a good moment to mention that we're running a course. We've got 2 courses of the London School, one in Calgary, one in Michigan. The Calgary one's going to be here. If you turn to the second to last page in your programs, second to last page, you'll see it advertised there. It's just opposite Bill's course. And of course, we're advertising all of our courses here. And the London School, if you want to come to the London School, there's some flyers here. That's the A3 style flyers. And on the reception desk outside. And of course, I'll come to that in a second. So we're wanting to promote more education and events. We're wanting to build quite a sophisticated member section, and we are making arrangements with the North American group that they will have some access into some of these. But I would also encourage people who aren't a member of the North American group to sign up with the International Association. You can become a member of this International Association. We're going to have onerous benefits to you. Everything from the video I've shown you today, lots of other videos like that. We've got a forum where Dad and me will be in residence. And lots of all of the sort of things that I've done already. Yeah, I've done lots of paperwork. I've done consent forms. I've done all of these sort of things. Come and join, download them, have them. And of course, we've also made this a bulletproof site. It's hosted on 2 different servers. It's hosted by 2 different hosting companies. It is about as all singing, all dancing as you can get. We estimate it would have cost about $500,000 to build a site like this had you gone to a normal construction site. And we want to do some research. And we've got some research software embedded in this that helps people to organize their research and keeps account on the research. And if you need some statistical help, we can provide the statistical help. We've made research, we've made relationships so that can happen. If you do ever see that site, that's the 3rd backup site. And that's just to tell us to do something if that comes up. So if you see that site, tell me. That means all the other sites have gone down. And that's the 3rd backup. So here we are. This is these are some of the courses we're putting on at the London School. So that's the leaflet down on the front here. Here's the program we're going to be doing in Calgary that starts in July. We're looking for people today. Do come and talk to me if you're thinking about that. That's going to be a very clinical, hands-on approach. We'll be running that partly lecture-based and partly in Darren's office. And of course, final thing for me to say is the next event. The next event's going to be in Melbourne in October 2015. Can you put that in your diaries now? Save that date. I've got flyers for that down on the front here and on the reception desk outside. Do help yourself. There's not enough for everyone. First come, first served. Okay, now on the clinical side, any other questions? Cool. Anyway, so it's been a pleasure to come and talk to you today. I hope that was entertaining. Thank you very much.